our session from SightFirst Eye Hospital. My name is Patricia Warui, and I shall be your moderator for this afternoon. Joined by Dr. Rilwan Adan, who is the head of the Diabetes Care Center at Lions. She's also the Chief Medical Officer at the Health Technology Startup. She is also the Vice President of the Kenya Diabetes Study Group, co-chair of the Ministry of Health Technical Working Group, Cardio-Metabolic Conditions, and a member of the WHO Global Coordination Mechanism on NCDAs. Karibu Daktari. Also joining us is Emma, who will be taking us through the board perspective. And Emma is part of the SightFirst Eye Hospital board. She is also contributes to perspectives on leadership, governance, stakeholder relations, and community engagements. Karibu sana, Emma. Our session shall be quite interactive. We shall start by probably telling you a little bit about ourselves. We have a slide talking about the SightFirst Eye Hospital. We are based in Loresho, for those who don't know us. We are basically a healthcare service medical facility. However, we have also joined into other multidisciplinaries where we have the Diabetes Care Center, we have a dental service unit, we have an ENT clinic as well, laboratory and diagnostic services. We are based in our main clinic, which holds all these services, is in Loresho. However, we do have satellite clinics that basically focus on eye health. That is Village Market, CBD Town, Mpisha, Nyeri, Southfield Mall, Isili, and JKUAT. And we are happy to sponsor with any of you who are here as corporates, as healthcare partners during your webinars, during your healthcare events, and even corporate events. And also, we still welcome you once again to take advantage of today and tomorrow to do your screening for your eyes, eye pressure. I had people asking today, what is eye pressure? And we have also blood sugar, blood pressure, and ENT services. We have our specialist there, Dr. Salim. Probably I'll start the session by just asking a quick question. When did you last have your comprehensive wellness check? Just by a show of hands, is it in the last 6 months, 12 months? So probably you can show me by a show of hands if it's within the last 6 months. Anybody? Okay, we have 1, 2. And how about 1 to 2 years? The past 1 to 2 years? 1, 2, 3, 4. More than 2 years screening? Not at all done any screening within the past 5 years, probably? Okay. So I'll go to the second question, which also I'd like maybe to know from your end. Which health numbers do you currently know? Okay, not the ones that you got when you came to our stand, but previously, did you know your health numbers, maybe your blood sugar, your blood pressures? By a show of hands, how many currently or frequently test themselves? At least half of our audience. Thank you. So I'll start with Emma. Emma is part of the board, as I said, and her question basically is on what are some of the warning signs that leaders may be experiencing but ignore?
Thank you very much, Patricia, and to the audience. Some of the problems that we ignore, just from the previous sessions we've had, and some of the things that maybe I've experienced as Emma is lack of sleep, one of them, poor appetite, among others.
Thank you, Emma, for sharing. I don't know if we have somebody from the audience who'd like to share some of the warning signs probably you feel could be alarming and you ignored before, probably a certain illness or a certain discomfort? Anybody willing to share? Swollen legs, yes. I come or can hear? Okay. Blurry vision, low pressure. Thank you. So, Dr. Rilwan, what are these signs that we ignore sometimes? And when we are coming to you, either it's too late or we are going through even more severe conditions.
Uh, Thank you, Patricia. I would like to congratulate the Women on Boards Network. I think this is an excellent initiative. Um, I'm a physician specialized in metabolic health, but I have special interest in women. So I sit on a steering committee for WHO, which is basically about the health of women and girls. So before I get to that, I want to emphasize at your leadership level as women here to know that for women, we just do not look at our health alone. Our health um, influences health of generations to come in the metabolic health space. Because what you're eating now, what you're exposing yourself to as females, especially in the reproductive age group, when you're pregnant, your children actually would depict those symptoms in the later generations. So in the women health space, especially the metabolic aspect of it, we're looking at what we call the life course approach when we look at these things. It's now influencing the next generation. I have patients who come to me and say, I've never had diabetes in my family. What is happening? Why am I the one having diabetes now? It's because of those life course changes that have occurred. We have food surplus right now, so we are enabling what we call genetic changes, epigenetic changes. The environment is changing our genes. And now we are developing genetic conditions which were not previously in your generations. So this fora is actually quite important because this is the cohort that now influences. If you're in the reproductive health age group, or you have your children in the reproductive health in the reproductive age group, this is when you influence these changes. So now coming to the questions, is a lot of the metabolic health conditions that we have are actually silent. Hypertension, one of them, we call it a silent killer. Number one cause of heart failure, diabetes, number one cause of kidney failure in our country. These conditions don't have symptoms. So in the initial stages of these conditions, you feel a lot of nothing. So in terms of you don't have any symptoms, there is no pain, there is no swellings in terms of saying I'm having a swollen neck, I'm having a swollen hand. So we don't have a lot of symptoms to depict this. We have non-specific symptoms. And one of it is actually fatigue. You're tired. You're always tired. So this cohort probably lives a high executive life, and your tiredness may be attributed to your work life in terms of I'm tired because this has been a busy week. I've had flights in and out, and I've been in the office till late night. So fatigue is one common aspect. Somebody mentioned burning sensation. Pre-diabetes, even before we diagnose diabetes, pre-diabetes can present with burning sensations, what we call neuropathy, neuropathic changes, the nerves slowly getting damaged. Hypothyroidism can easily present as that. Somebody talked about leg swelling. You're talking about your veins now not pumping enough blood back to the heart. You're talking about venous insufficiency. So most of these non-communicable diseases which lead to the metabolic health conditions eventually now coming to your diabetes, coming to your hypertension, coming to your heart failure, coming to your kidney failure, all initially are quite silent. There is a type of heart failure we call heart failure with preserved ejection fraction. The only symptom it has is easy fatigability. You may not be able to walk as much as you used to walk before. So these are symptoms which are quite hidden. Emma mentioned lack of sleep. Lack of sleep, or rather sleep disturbances. We have obstructive sleep apnea. Patients are not able to breathe well at night when they're sleeping, so they have these apneic attacks, waking up tired. You don't feel rested, even if you sleep for 8, 7 hours, you wake up tired. So those are kind of a few symptoms which actually come out glaring, that there's something building up down there that you actually need to have your numbers known.
Wow. Emma, like to add on something? Wow. And those are the conditions we are talking about. They really just emerge, but you're not even aware about them because probably you're busy at work, you're rushing to the next board meetings and all. There's a question that we got a lot at our stand, mostly in regards to weight, nutrition, and these drugs that we are being told about, the GLP-1 medicines. Now, Dr. We are not sure whether these drugs are safe, whether these drugs, I mean, what if something happens? What if my kidneys will fail? From a professional aspect, what do you think about these drugs, and when do we seek these drugs for weight management, diabetes risk, metabolic health? When do we come to you as a clinician, physician, for these kind of drugs?
If at all any of you in this room lives with nothing today, I just want you to live with one thing. Overweight, obesity, weight is a medical condition. Just like diabetes is, just like hypertension is. So if you're overweight, you have a chronic medical disease. If you're obese, you have a chronic medical disease, which you need to seek help for. So the GLP-1 analogs, famously known as Ozempic. So first of all, we're very happy in the medical fraternity. We're getting the original
Yes.
in the country, and it's being launched 12th of September, which I happen to be one of the speakers for it. So Ozempic, or rather GLP-1 analogs, we have what we call GIP, GLP-1 analog, which is the Mounjaro. So these drugs were initially developed for treating diabetes, and weight loss was seen as a side effect, which was a good thing because weight drives diabetes. So for most of our patients who have diabetes and have lost weight have actually gone off medication and have gone into diabetes remission. So they don't have the symptoms of diabetes anymore. Their sugars are well controlled. So the indications for this medication is if you're overweight. First of all, how do we diagnose obesity? How do we diagnose that you're overweight? So what we usually do is calculate the BMI. So BMI is actually not an accurate marker in my office when you come to me. It is a good marker at the population level for screening, at the public health level for screening. And then you go to your doctor and say, I've been told I have a high BMI. BMI is a factor of weight and height. Weight can be contributed by fat, can be contributed by your muscles, can be contributed by your bones, can be contributed by your water body content. So all these are heavy and it contributes to your weight. So what we look at in terms of weight and obesity and overweight and obesity is the fat, which is the problem, what in medicine we call adiposity. So fat is the major thing. So if I have something targeted just to get off the fat of individuals, that would be perfect. However, GLP-1's GLP is not directly targeted only to fat, but it's targeted to overall weight. So what we look at to diagnose obesity is actually the waist circumference. Okay? So the waist, usually what we call just the lower rib. So the waist, when medical waist that we measure is just under the lower rib and what we call the anterior superior iliac spine. This bone here that you feel when you touch. Yeah. So right at the middle of that is where you measure the waist circumference. So for females, ideally they should not have a waist more than 88 centimeters. The other thing that we look at is the waist height ratio. So you take your height and you take your waist. Yes. So if that ratio should not be more than 0.5, ideally half of it. So if you have that, that now is obesity, and these are the people we give these drugs. Number two, those who have diabetes, hypertension, high cholesterol, other metabolic conditions, and are overweight. So we don't wait for them to get into obesity. They have these conditions, we give them the medication. Remember, there are so many silent conditions associated with obesity. So obesity is sort of the precursor of a lot of the conditions we manage in the metabolic health space, including high blood pressure, including diabetes, including fatty liver disease, which is now amongst the biggest cause of liver failure, including obstructive sleep apnea, including arthritis. So once you get the patients to lose weight, all these conditions actually improve. Now we are looking at it for GLP-1 analogs as an indication for addiction in terms of alcohol dependence. It's actually getting people off alcohol. It's so there is a lot of indications coming for it. Those with autoimmune conditions, basically inflammation, it reduces inflammation. So all the semaglutides, all the tirzepatides, we're looking at it for that. Now my problem is how it's being used, especially in our country. So
And the myths we've heard about.
so yeah, the myths are many as well. Just recently, we had a patient who was initiated these drugs in a spa, the spa where she goes to, and this is a once weekly injection, and she was not told how to use these drugs. So she was injecting it daily. So you can imagine a once weekly dose, now somebody is getting it daily. So a lot of health hazards that can come with that. Myths around it is blindness. One of the commonest is blindness. That is why this is a prescription drug. It should be initiated in the hospital by preferably the specialists. For even now at government level, we're trying to, with the technical working group that I work with at MOH, we're trying to say they be initiated at level 5 and 6. So not even at the lower cadres, because there are a lot of caveats that are associated with it. So the side effects profiles is huge. There are contraindications, especially what we call medullary thyroid carcinoma. If patients have genes for it, this is a genetic disease. So if they're not supposed to, it's contraindicated completely for patients who have this to go on this drug, pancreatitis. So we need to have sort of a full profile for these patients, a medical history, so that we can be able to know you're a candidate for this, you're a candidate for this. Because now there are many others coming into the market actually. So the FDA approvals are going on. So we need to actually sort of limit how we are using it. Not limit it for those who will benefit from it necessarily. So GLP is what we call glucagon-like peptide. It's a drug which we use once a week for obesity. It's an injectable. So how GLP-1s is, I think commonly, famously, I think became quite famous through
Ozempic.
Oprah and all that.
Yeah.
And Ozempic, yes. Yes. So Ozempic is a GLP-1 analog. So it works in the stomach. How it works is everybody has GLP naturally, occurring GLPs, but naturally there are enzymes which degrade it very fast once it's produced. So GLPs are produced once you put something in your mouth, you eat, your body produces your own GLP, but there are enzymes which actually degrade it quite fast. So now the analog is something that is similar to that, because if you have it prolonged in your system, you have that sense of fullness. So you don't feel hungry. So I have patients who've gone 24 hours without eating who are on it. They actually forgot to eat because they were very busy. So you actually do not feel hungry completely. It works on your satiety center for you to feel full. So that is one of the mechanisms that causes weight loss. What I want to also emphasize is obesity as a medical condition. The main driver is actually not only how we eat. It's what we call a it's from the brain. The driver is from the brain. So a lot of stigma associated with weight. We tell our patients it's not their fault that they have obesity. It's not their fault they have or they're overweight, because there are hormones in the brain which actually drive one to eat and works on the appetite center. So the appetite center is in the hypothalamus. So there is that continuous stimulation of these centers that people just pick and eat and do all that. And then the other thing is, I think at lunch we were talking about being a sweet tooth. People who always crave sweets and want to eat something sweet, that is the driver is actually insulin resistance.
Yes.
So insulin resistance is your first stage now of now going into diabetes, because type 2 diabetes especially.
Yeah.
And patients can have insulin resistance for up to 15 years. This is what we're talking about, hidden aspects of your metabolic health that have been ongoing. And then one morning you wake up and say, you're told your sugars are high. It did not just happen overnight. It's been culminating over years and years and years. So especially for the women, now we need to look at the age aspect of it as well, because now as we grow into the older age group, it becomes even more difficult to lose the weight as compared to when you're younger.
Wow. Thank you, Dr. And can I say that responsible weight management then must be medically guided and not just like a trend? You know, the way the influencers are influencing us young people to just do the pricking by yourself. I'd like also to move over to the audience and just hear what kind of maybe questions you may have, myths that you've had, and if, in case there's anybody who has any questions, it's good to push it over right now.
So this,
Yes.
so
Yeah.
so usually, like when I take a patient through weight management clinical consultation, it takes a bit of time, because the most important thing is this is a lifestyle condition. And so we need to discuss your lifestyle in terms of how you eat, the contents of what you eat, because it's not isolated. Like Patricia mentioned, it's not a quick fix drug, because I have youngsters who come now, 28, 29-year-olds. I have a wedding to attend. I have to fit into this dress. I need this. I need to do this. So we don't actually like just, it's not a quick fix. Yeah. That's why I started by saying it's a medical condition. It's chronic. We give it for over a long period of time, and that's how it works. So the side effects associated with it are, number one, like I told you, the mechanism of action is it works in your at that level, at your stomach level. It reduces gastric emptying. So when there is food in your stomach, the brain is sent a message that goes. It's called vagus. There is a message sent to stop sending the message the person is hungry. So the brain automatically takes the message. Now you feel that fullness. So it slows gastric emptying. So over a long period of time, 8, 9 hours, if you had breakfast at 8, at 4 p.m. you'll still have that in your stomach, that slowing of gastric emptying. So there is no peristalsis like usual. Interrupts that. So what happens is, if you don't look at the frequency of your eating. I know Diamond has treated you guys very well. You're having breakfast and then 10 and then at lunch. So, so if you were on a GLP-1, you would not sustain that, because you can't have breakfast at 8 and then at 10 you're having something else, and then at 1 you're having something, at 4 you're having something. So what happens is the side effect you get is bloating. So you start feeling that you burp, and then now you feel the smell of food coming, because now the food, there's hydrochloric acid from the stomach, which is fermenting the food and all that. So you tend to get bloating. So when you bloat, you tend to get osmotic diarrhea, because now there is that osmosis aspect that is happening. And then some people, when they overeat, they get vomiting. So that is another common, and nausea as well. You get nausea, you get vomiting. Those are the commonest side effects. But for patients who go through proper clinical consultation, and the thing about weight management and GLP treatment is we also plan their meals. So depending on now your lifestyle, how you manage your food. So it's more individualized meal planning. So we plan your meals. The frequency, probably for most of my patients, frequency reduces. So a lot of patients go on twice a meal, two meals a day. There are some who've gone on 1 meal a day. And then also the portions go down. So you cannot be able to hold as much. So we avoid fatty foods, a lot of deep fried foods, basically, spicy foods. So those, looking at those meal planning aspect, you tend to be able to reduce the side effect profiles for this patient. Those are the biggest side effects we have. For those who've had history of having pancreatitis or chronic alcohol use and we're not really sure how their pancreas looks like, we try to avoid to be able to be sure. For those who have uncontrolled diabetes and they've started having what we call retinopathy, we look at the severity of the retinopathy. So what we call a post hoc analysis of what the major trials that were done on these drugs have shown that there were calls of the drugs causing blindness. So most of that was along the lines of those people who had severe macular edema and retinopathy, that the damage caused by excessive blood sugar for those who've had diabetes for so long and uncontrolled for that matter. So those are the major side effects we have. A lot of my Asian population patients that I have put on, and this is anecdotal, it's not from the major trials, is I've seen that they tend to have a bit of hair loss. The soft hair usually thins out a bit. And so we supplement these patients. And once we supplement them, I've seen the improvement in that. And the other thing is about bone health. Remember, like I said, this drug is not entirely targeted to the adipose or the fat tissue. So you tend to lose muscle mass. And if at all, the next thing that you leave this room with, apart from obesity being a medical condition, is muscle. Muscle is a very important organ, especially post 40 years. The more your age adds, the more you lose your muscle. So even if you're not on a GLP-1 analog or any weight loss therapy, just know that you're losing muscle. And so muscle is a big organ in metabolic health. It's the main organ actually in metabolic health when you talk about insulin resistance and weight. Because when you have insulin resistance, you tend to have hyperinsulinemia, a lot of insulin. And insulin is a weight gain hormone. So you tend to gain a lot of weight. So if at all anything for all of us, including me, is we need to work on our muscles, because this will determine when you reach your 75-year-old, when you're 65 years old, when you're 80 years old, the level of frailty and independence that you will have. Because if your muscles are not strong, you tend to. So you get a lot of muscle wasting as a side effect of this drug. So if you're not doing your strength training exercises, you tend to go into what we call sarcopenic obesity. Now you become more frail and more weaker as you age. So muscle wasting, muscle loss is one of the other side effects that we tend to observe in these patients. And with muscle also, you tend to lose a bit of bone. Remember, if you're postmenopausal now, you already don't have estrogen and you're already becoming osteoporotic. So you tend to, your bones become weak. So you can also lose some bone mass with this drug. So we tend to supplement them a lot with vitamin D. Vitamin D, I don't know why it was called vitamin D, but it's an excellent hormone. So enjoy the sun in Mombasa while you're here. So sorry, I have to think a bit because I'm so used to giving talks to physicians, so I have to translate. I'm trying to not use medical jargon. So basically, the trials have shown clearly, once you go off the drug, you actually tend to regain weight. Not necessarily more weight than you have before. So if there is a scientist here, probably they could look up the trial. It's called Step 4 trial for the Ozempic, and Mounjaro, it's the Surmount 4. So what happens is this is a chronic disease. So for my diabetes patients, if they don't take their diabetes drug, the blood sugar goes up. For my hypertension patients, if they stop taking the medication, the blood pressure goes up. For my weight patients, if they stop taking the drug, their weight goes back up. So it's a chronic condition. That is what we like telling people. But I have had patients who've been on this drug for 2.5 years, almost 3 years. I have those who have attained the weight that is ideal for them, in that they've lost several stones and now their trouser sizes are way down. Somebody who was size 22 right now is size 14. So we tend to try and attain this weight loss at the maximum dose of the drug. So we step up the dose. So always we start, that's the other thing about the spas. They don't know how to like titrate the dosage of the drug based on the patient. So we start at the lowest dose and we titrate based on your need and based on, so essentially metabolic health is individualized. So highly individualized. So that cake that you've eaten, somebody else eats, the impact is totally different for each and every person. So the same way the therapies that we give is also highly individualized. So what we do is, there are patients who we've stepped down on the dosage of the drugs and kept them on a maintenance dose. There are patients who have actually stepped off the drug and have maintained on intensive behavioral and lifestyle management in terms of their diet, their physical activity, but they've gained a bit of weight, but not as much as it was before. But these are patients, again, we follow up because they can go into rebound weight gain. Just like our diabetes patients, we've been taking patients off diabetes treatment for those who've gone into diabetes remission. But these are patients who we tell, you still have diabetes. It's only that it has now gone into remission. So we still follow them up. So we still follow up these patients, and based on that, we reinitiate or we keep them off the drug if they do not need the drug. So your question is not quite a definite answer. It's dependent on the patient. But the fact is, weight is a chronic condition, and there is definitely chance of rebound, but not more than what it was before. I'm yet to see that, but even in the trials, it wasn't more than what it was before, but it was a definite weight regain.
A question. I'm the lady who asked about the relationship between high blood pressure and venous insufficiency or varicose veins. I don't know whether they are different. What are the relations? Yesterday I learned that blood pressure is more on the artery side, not on the veins, but you could have they could coexist with each other. So that's what I noticed in our case with my dad, where the hypertension then became heart disease, coronary heart disease. Then it affected many other organs, including the veins. And sort of just to ask from your clinic whether for women, I know many of us suffer from varicose veins or spider veins, mostly varicose veins, and sometimes they hurt. So, and of course, they're not good to look at wherever they form. So, is there an intervention currently in Kenya that can be good for that?
Yeah, absolutely. So venous insufficiency, I think most of us, especially on those long haul flights, we come out and you find your legs are swollen very easily compared to your colleague who you traveled with. I'm one of them, by the way. So venous insufficiency is on the vein side, like you said. Hypertension is actually called arterial hypertension. So it comes from the artery side and they can quite coexist. So in terms of management of venous insufficiency, it depends on the stage where you are at. Some can actually, by insufficiency, insufficiency eventually ends up being varicose veins. And especially for women, pregnancy is a driver, contraceptives, standing for long, if you're a person who stands for long. These are things that exacerbate it and makes it even worse. Usually the pressure stockings in the initial stages help to pump because your pressure stockings are really quite the veins pump the blood back to the heart. And then you have some drugs which are in the market, which we give for some patients. If they're really, so the thing about varicosities is that if they've been out for so long, they're somewhat with that sclerose, so they become hard. Some you touch and you see it's actually quite, the vessel is still quite elastic. They go in and out. And then there's some which starts becoming hard and they what we call sclerosed. So those ones, they still levels. The cardiothoracics usually work on it. There's some at the level of even surgical intervention where you call venous stripping from what we call the saphenous vein. So the saphenous vein is the biggest vein that comes to the lower limbs. So there is what you call stripping of it. So the interventions is quite a spectrum depending on the level where the patient is, from the medical aspect now going towards the surgical aspect with the cardiothoracic surgeons who actually usually deal with that. And I think currently there are also interventional radiology measures, which now still being done by the cardiothoracics or interventional cardiac surgeons who actually deal with it. I have a colleague who actually just went to Canada and actually just specialized in veins at AKU. So it's quite a spectrum, the management of it.
You had a question.
It's not a theory, and when I say the clinical consultation with our weight management patients is quite long, is because part of the history is try to ascertain the genesis of this weight and obesity. You have a lot of genes which are involved in weight gain. I don't want to name a few of them, but MCR4 is one of the commonest actually, that there are genetic changes, and you see this running in the family. And then there are genetic syndromes now that come as syndromes. So let me not. There are genetic changes, epigenetic changes, which have happened over time, and people now in the same family have that. And then the syndromes are now even born with what we call Prader-Willis. Now they're born from a young age. Now they're that family. But then now you have single gene changes which also happen, which are quite many actually. So yes, there is that aspect. We try some of the drugs we give to deal with something can, as a side effect, can be a weight gain. Steroids, for example, for our patients who have all these autoimmune diseases, steroids are excellent in terms of managing those conditions, but the side effect is it will give weight gain, it will give diabetes, it will give hypertension and all that. Yeah. Some of the epilepsy drugs that are there in the market, they tend to cause weight gain. Some of the antidepressants and antipsychotics that we give our psychiatry patients tend to cause weight gain. So we talk to our colleagues and say the newer drugs, at least for most of these conditions, tend to spare the weight. So if they can afford the newer drugs, we put them on this. So genetics is a cause, but definitely now the joint pains are as a result of that weight. So those are patients we give these drugs because now it can, in fact, even orthopedics who you go to right now and you tell them about the knee, and these patients have arthritis and they have to undergo knee replacement, they'll initially put you on this drug to try and reduce that weight, because even that knee that they replace, still the weight on it might not be that much. Now the obstetricians, patients who are trying to conceive and have weight, they're being put on this drug because now that weight is preventing them from conceiving. So we tell our fellow other specialists that they're trying to steal a drug which is ours. But what we're noticing is that it's working for so many other specialities. Kidney failure, Ozempic works excellent for patients who have chronic kidney disease to prevent them into going into kidney failure. So heart conditions, the same, heart failure, the Ozempic is excellent for it in terms of worsening heart failure, and heart failure hospitalizations are being reduced because of this drug. So basically, the the consequence of obesity in so many other conditions is actually these drugs, the patients are benefiting from these drugs, not only at the metabolic health level, but also other levels. Now they're studying it for Alzheimer's and Parkinson's as well. So excellent, because they're all pro-inflammatory conditions. It is a diabetes medicine. So Ozempic is actually, Ozempic is semaglutide. So semaglutide, we start it at a dose of 0.25. So up to 1 milligram, it's called Ozempic. So it's used for diabetes. So when it comes to 1.7 milligram, 2.4 milligram, we call it Wegovy. And Wegovy is now in the US what is FDA approved for weight. So we are using Ozempic for weight, but the weight loss with Ozempic is minimal. So when you go to Wegovy is when you get good weight loss. Actually, Ozempic is not FDA approved for weight loss. It's not FDA approved for obesity. It's FDA approved for diabetes.
It's the common name for all of us.
So even if you're using semaglutide for weight loss in obesity, you still have to first start with Ozempic. Now go to the higher dose of Wegovy. Okay. So yeah, I think the influencers are working so much harder than us to give them information, I think.
Well, we could talk about weight. Somebody told me today they want to gain. So I don't know now whether we'll have a drug for that too. But
so weight is now a subspecialty. Obesity is now a subspecialty, just like a cardiologist is. We have obesity specialists standalone. Yes. So it's actually quite a wide topic when it comes to now even talking to the molecular level of all these genes that cause this.
Yeah. Oh. I want us to move to the next question because I know we could be here all night, all day talking about this weight. So we're moving on to the big M, menopause. So it's been also a conversation in the wavelines. Everywhere women are talking about menopause. So would like to know how many of us are able to identify some of the changes that menopause comes with, and what screening now from your end would be the recommended support that we need from a professional side. But I can first start with the audience. If you're free to share, what are some of the changes that maybe you feel? We talked about a few probably. Why are you laughing? Yes. Yes, weight gain. Hot flashes, yes. Mood swings. Pardon? On your end? Mood swings, yes, correct. So I don't know how we identify if those all fall under menopause or they are our excuses, but would like to understand more about these changes that
Thank you very much. Are those the only symptoms, by the way? How many of us are between 20 to 30 years here? How many of us are in the age bracket between 30 to 40? How many of us are in the age between 40 to 45? 50 to 60? Thank you very much. You know we are all women, by the way. And gentlemen.
And one gentleman.
Now, whatever I want to talk about is a bit sensitive. Over 60 we also have here, Cindy. Thank you. Congratulations, my dear. What we want to talk about is a bit sensitive, but it is the reality. Apart from the mood swing, how is your sex life? Between 30 to 40? Thank you. But then even if you have to go through it, has some things changes? Why do you think we have things like KY jelly? But we even have better ones in hospitals, which you'll be told, by the way, you have to buy by cash. They're not covered in our medical cards. Are we aware of that? For the gentlemen in the house, I hope we have women. If they're not yet there, then expect some of those changes so that you don't go for those other cases we've been told in the legal case before. But those are some of the realities. And that is why we have Dr. Rilwan to take us through some of those. And you know, we are leaders. We are in various boards whereby we formulate these policies and we can amend them to accommodate some of those needs that women need. For example, if you need supplements, how many of us have medical covers? Do your medical covers approve for medical supplements? For mine, they do, by the way. On specific cases, yes. CIC. But now, depending with your age and the condition, you have to send approval to customer care and they approve. But it means in various boards where you are sitting as women, you can also champion for this. And that is why we are here, and that is why we have this topic. So we don't let women suffer out there. To you, Daktari.
I just want to echo the sentiments which she has said. With your capacity here on boards, I think you can carry that I think weight of determining, especially the medical covers for your companies, what they can cover and what they cannot cover, because we have people coming to the clinic actually in tears. So one case in point is the drug we've just talked about, the weight loss drugs. It's not being covered by insurers. I've given talks to actually care managers of insurance companies about some of these drugs. What they don't look at is that these drugs are preventing complications. The insurance wants to cover complications, but if we can prevent these complications, I think there'll be a healthy workforce. Productivity in terms of, how many days you're losing at work and all this, I think at this level is where you're supposed to look at how many days off work are people getting to come to the clinic to manage their chronic conditions, when in the actual sense, these chronic conditions can be prevented. So as you champion for other things, please, for the productivity of your workforce also, look at some of these medicines to be covered by the insurers. So the big M, as I wish there were more men in the room, because I think Patricia was actually asking me what specialty usually covers menopause and all these things, because menopause in our country, a lot of patients actually go to the obstetricians, and gynecologists. Same case with PCOS, or now it's called PMOS. People tend to go to the obstetrician, but these are hormonal issues. So we're the ones who actually deal with it. It's a metabolic health issue. It's a hormone issue. So it's usually dealt with by the endocrinologist, by physicians, actually. Obstetricians are surgeons, so they love cutting. So they don't like hearing stories. We love stories. So menopause, I think the biggest aspect which we are currently managing is more around the perimenopause. All those symptoms you mostly talked about, especially coming into the 40s, early 40s, mid 40s, early 50s, perimenopause is a big factor. There was a study done in 2001, or is it? Hormone replacement therapy was actually sort of banished to oblivion, because the study showed that it's associated with cancers, and if you take hormone replacement therapy, you have a high chance of getting cancer. And so now all of us, the physicians, everybody, the medical fraternity, actually all shied away from prescribing it, and we stayed away from it. In 2024, we got a recent study which showed that these are actually excellent drugs, because they tend to improve productivity for our patients and quality of life. So I recently had a patient, she's an executive, and she was due for a promotion. And she was in my office actually in tears, crying, because she said she lost the promotion because she's moody. She was told she's moody. She does not, she can't, they can't determine what will happen next with her. So one day she comes, she's okay. The other day she's out of her element and she doesn't want to talk to anybody and all that. So these are the things we face every day in clinic for our patients, especially in this age group where they're undergoing the perimenopause symptoms. All those are symptoms, but there's some of them which you cannot explain, because when you get symptoms you cannot explain and you're in this age group and it's affecting your quality of life, we tend to initially start them on very low dose of the hormonal therapy, especially the vasomotor symptoms like the hot flashes. There are people who actually have very bad hot flashes. It affects their sleep, it affects. So, the whole thing is kind of a spectrum, a continuum. So now what is happening is you've always had very high estrogen and progesterone. Now with your normal cycle, it has been alternating estrogen, progesterone. Now it reaches a certain level now at a certain age, now mostly early 40s. There's some who late 30s as well. These hormones start declining. So when they start declining, the estrogen is an excellent hormone. I think it's God's gift to a woman because it's actually, all these symptoms are because now your estrogen are going down, the hot flashes, all that. So when they start going down, now you start having these symptoms which you cannot explain. I had a patient who she said she has a problem in her ear. Every ENT has, I think in this country, has seen her. And we could not actually determine. We gave her HRT and she's like, I don't know what you're talking about. What ear problem? So some of the symptoms actually cannot be explained. But the screening that we don't do it regular screening, but we check the estrogen hormones, progesterone hormone levels, and they tend to go down. Yeah. So by the time you're at menopause, now menopause means perimenopause is that now 10, 15-year period. Studies say in the Black population, it comes a bit earlier. So it in the Caucasians, it's a bit later in their 50s, 55-year-olds. So they tend to get that perimenopause symptoms a bit later than us. So the dwindling of the hormones is what leads to this. And routinely, we don't even do the hormones, but there are patients who want to know what my estrogen level is, what my progesterone level is. And those who are trying to conceive, there is what we call AMH. We check their AMH levels so that we can be able to know, are they even producing eggs or rather ovum for them to be able to conceive. So giving the hormonal replacement therapy in low doses, initially we start low and it improves the quality of life. That's a sign that this patient is having perimenopause, because you have a high functioning executive person who just decides, I'm not going to work for 1 week. I just don't feel myself. I don't want to talk to anybody. So that is affecting your life. Yeah. So we tell, let's just, the hormones, especially the estrogen, it's sort of a cream. So, or the patch, whichever is available for the patient to buy. Most of them, there are very few in the country. Some people importing from UK, so they're quite costly. So for patients who have a uterus and they've not had a hysterectomy, they have to go on progesterone as well, not estrogen alone. So those who've had a hysterectomy, we can just give them the estrogen alone. Those who are trying to conceive, we give the progesterone half the month. Those who don't want to conceive, we give progesterone continuously. So we manage based on that. What Emma talked about, the sexual function, is a big issue. The estrogen vaginal creams comes very much in handy for most of our patients. A bit of testosterone, very low dose for those who have completely zero libido, because libido, there is no sexual function without libido. So the testosterone in very, very small, minute doses actually helps with the libido for these patients. So menopause now is when now you've not had your menses for completely 12 months. So now we can say now you're menopausal. So you're not perimenopausal anymore, because when you're perimenopausal, you get your menses today, then after 3 months, you're okay. At the 4th month, it's there, and then another 5 months, it goes. So when you miss the menopause, menopause is now for complete 12 months, you've not had your menses, so now you're at menopause. Then now comes the post-menopause. So now you've had that, and now you go into post-menopause. I was telling Patricia, I was giving a talk just this Saturday to a group of physicians, and I was talking about life course, and menopause was part of it for women. And I was showing her the slide I presented where I was telling physicians, menopause is not a hot flash problem. Menopause is slow motion, your cardiac health, your physical health. So it's now the stage where you go into, now your chances of getting a heart attack becomes almost double compared to when you were 30 years old or compared when you were 20 years old. That's why I'm saying that estrogen is an excellent hormone. Your chances of getting a stroke now becomes very high. So it is what we call a cardiovascular means the heart, the vessels, and all those the organs that attach to it. Now it's a continuum of disease that is happening in slow motion. Somebody mentioned weight gain. So actually, studies have shown that the fat around your hips and your thighs are actually protective for the heart. But now, when you go into menopause, that fat moves to the abdomen. Even if your weight is good, you start getting this, yes, it just goes there. So, that abdominal obesity, the more it grows, the more your risk for heart attack, the more your risk for heart failure, the more your risk for stroke, the more your risk of peripheral vascular disease, all now starts now growing. So it is very important for us to acknowledge that menopause equals heart health. So that is the other message that we should leave here with today, that once you're now getting into menopause, you know that now your heart is now on a delicate balance that we need to take care of. The other thing is muscle. You're losing muscle now at a tremendous level. So we talk about a high protein diet. A high protein diet is good for everyone. In fact, studies say 1.2 grams per kg. So if you're 100 kilos, at least you should have 1.2 times 100 is 120 grams of protein. So that is what is advisable. But when you get into menopause, perimenopause, the amount of protein your body can absorb is not the same as the 25-year-old. The 25-year-old absorbs more protein than you. So we talk about now the anabolic. Now your level of breaking down the protein is fast. Your level of absorption is also slow. So that's now you find people now starting to slow down, because muscle is what is carrying your body, your skeletal, your bones. So if your muscles are weak, if your muscles are kidogo and you're losing it, and then remember estrogen is not there, now everything is fat. You're replacing all those muscle places with fat. So what I want to encourage everybody is strength training exercises. Walking is good. Keep walking. It's cardio. It keeps your heart rate, keep your heart rate high. It's good. But please get to lift some heavy things kidogo. Please don't go today and lift a 20-liter jerrycan and pull a muscle, please. But it's continuous. Build up kidogo kidogo. Please, strength training, strength training, strength training. Very, very important. If you don't lift weights, use your body weight to be able to strengthen your muscles in menopause.
I can see a question behind.
I would wish I would wish to ask on three indicators, but they are also related to menopause. Someone said blood vision. Assuming you had this blood vision even much, what would you expect in menopause? Especially saw some people who we are in meetings like on and on and on. We are on the laptop on and on and on, and then there are screens again. We are doing this. When would you differentiate between blood vision because of work-related issues and blood vision because of menopause? So, and also blood vision because of sugar. Maybe the differentiation on that. And then number two, there is this ENT challenge. Every time you feel like you want to cough, it's not there. Every time you feel irritation, it's not there. And I'm just trying to see, of course, you're saying people may react differently, and also with lifestyle. So one of the menopausal issues, and how would you work around that? And then my last one, allow me to be a normal woman. I want to continue being very active sexually. So if you said estrogen has gone down or up, I don't know. So what would you propose I use?
Those are three questions.
Okay. Um, So I've been asked here to start with the last question. I don't know. I so your I think remaining sexually active towards perimenopause, menopause depends on your sexual issue in the first place, because there's some patients who have libido and they're having vaginal dryness and they get what we call dyspareunia, painful sexual intercourse, and so they avoid sex because of the pain that they're feeling. That we have separate therapy for it. And then if you're having issues to do with libido, there are some who still do not have issue with vaginal dryness, but it's just libido alone. So that is a different therapy for that. And menopause is the decline in estrogen and progesterone. So that it's not estrogen going up. I wish, I really do wish, but it's the estrogen going down, progesterone going down. So when we talk about HRTs, hormonal replacement therapy, there are ways of giving these hormones. So estrogen, there are people who we do not give these hormones, especially those who have issues with breast cancer in the family, or there's some breast cancers which are genetic, which runs in the family. So we don't give people who have breast cancer. We don't give estrogen alone to those who have a uterus, because if you give it unopposed, it might predispose to uterine cancer. So we give it with progesterone. Now the progesterone dosage remains again with those who want to conceive. I have patients who are 49 years old who want to conceive and they come. I just recently had a patient who conceived on HRT and she's 49 years old. So again, depends on whether you want a baby at that time, and we give you these hormones. There's a way we give it to you. So it's individualized, the hormone. So probably we evaluate, we see what you need, and then based on that, we can push from there. Even for the sexual function, depends on what your pain point is in the sexual. The sexual sex is actually from libido to arousal to the act itself, and which stage actually are we having the issue is what we need to discuss for that as well. If it's libido, we give something. If it's dryness, we give something. So depending on that as well. So the other question, I believe, is around blood vision. So blurry vision, there are different causes of blurry vision. I wish you came with an ophthalmologist, but just from my physician knowledge, in terms of diabetes, yes, if you have very high sugar levels, because of osmosis, if you can remember chemistry, water will be pulled and your lens will not see well, so you get the blurry vision. So high blood sugars can cause that. But when it comes to this age, we're talking about now the 40s, 45, and we talk about the 50s. Now there's what is called presbyopia. Now that is more for ophthalmologists, where you now need reading glasses a bit, because now the lenses are also now, it's an age-related issue. So you see all old people read something, they have their special glasses, which they just put on. That's called presbyopia. Menopause is a spectrum. So somebody talked about sleep disturbances. When you have sleep disturbances, your metabolic health is disturbed, even if you're not in menopause. We see a lot in night shift workers and all that. Sleep is very important, by the way. Actually, it's recommended between 7 to 9 hours of sleep. If you're not getting between 7 to 9 hours of sleep, you start getting insulin resistance. So insulin resistance you get, now there's type 2 diabetes. Now there's type 2 diabetes and all the complications that come. So sleep can actually be a cause of type 2 diabetes. So that's something we need to look at. So when you have now sleep issues in your menopausal symptoms because of your hot flashes, or maybe because now your sleep pattern is affected from the brain because of estrogen. Now what do you get? Insulin resistance. Now you can start getting, with insulin resistance, those blurry vision, because people with insulin resistance there are periods they get spiking sugars. That's why somebody talked about burning sensation, same thing with the nerves. So you get those symptoms of diabetes because of now the spiking in your sugar levels because of insulin resistance. And then now you have your mood, which is also now affected by the sleep, and all that continuum together actually now affects your normal functioning physiology. That's why you're talking about also the cough in terms of the reflex that you're trying to clear. You're getting that sensation, but there's nothing coming up as such. So now that whole physiology is affected because of the interruption that the estrogen, the conundrum that it's causing. Yeah. I think the other question was about, yeah. So exercise physiologists usually advise in terms of, for those who don't want to lift weights, you have those lunges that you don't have to use your weights, but you're just doing your lunges back there. You have your sit-ups that you do. You use your body weight. You use your core weight to lift you up. So now that you're using your own body weight to function for you, to be able to do your sit-ups, your press-ups, your planks, your lunges. So that is using your own body weight without utilizing weights, actual weights. You strengthen those muscles.
That is quite insightful.
Or are we're running out of time. So
Yes, we are running out
if
of
you don't
time.
mind. And for you who are worried about menopause, Sarah gave birth to Isaac, 90. Oh, sorry.
Sorry?
CS. Oh yeah, she's obese, but a bit active and feels very cold most of the time. Could this be related to menopause? Now that they are coming
So-
even much earlier.
No. So, but there is what we call premature ovarian failure, by the way, where you have the ovaries failing quite early because of a specific reason in terms of commonest cause we get is chemotherapy. So we tend to, before cancer, probably harvest the eggs and keep for them. But there is premature ovarian failure for autoimmune diseases, which cause that. So those ones get menopause quite early. I've seen a patient who has menopause at 28 years. However, your patient that you're describing, just from the brief history, in medicine, we say we get the diagnosis, 80% of diagnosis is from the history. Cold intolerance is a big symptom of hypothyroidism. Hypothyroidism causes weight gain as well. So that's a patient I would ask to check their thyroid function tests probably. Commonly, that's secondary causes of obesity are hormonal conditions, which probably I should have mentioned. Hypothyroidism causes weight gain. Cushing syndrome, which is now hormonal excess in terms of cortisol. So if you have very high cortisol levels, and that's why probably a lot of you executives tend to be highly stressed. So cortisol is the stress hormone. So when you have high cortisol levels, you tend to gain weight as well. So you tend to see people associating stress with weight gain. It's because of the cortisol levels. So a patient who can't tolerate cold, even normal temperature, they're feeling cold, that is sort of cold intolerance. And that's a patient I would probably work up for hypothyroidism, because hypothyroidism also causes weight gain on its own, dry skin, all those other things, hairs falling and all that.
Thank you for that. Because of time, we'll go to Emma to give us her last parting shot. I'll be back to Dr.
Thank you very much, Patricia. And for the leaders in the house, have we learned something? My last parting shot. Your health is your wealth. Your health is your wealth. And it means you are the decision makers in this room. But it has to start with you. Because you have to be healthy for you even to be productive. So all of us, that is the slogan I want us to leave this room with today. Your health. Thank you.
Dr. Rilwan, we have the 90-day leadership health reset. What realistic reset can you give a busy leader, somebody who's currently in boards?
I think the word busy can be quite subjective. I think when you're talking about a reset program, probably should be highly individualized. So look at the patient and work with their schedule and how it works. When it comes to metabolic health, mainly around weight, around diabetes, around hypertension, around all these non-communicable diseases, it's lifestyle is always at the base of it in terms of there is no therapy without lifestyle modification, and this is a healthy lifestyle. And when I started talking today, I talked about the life course approach. And please take this home as women, because women are the backbone of our society. We are the ones who are raising the next generation. So when we talk about healthy lifestyle, it should be cut across for the whole family. Because I have patients who come and say, sikudunga dawa because chakula yangu haikukuwa tayari, because now they have a different whatever to the rest of the family. When we talk about 90-day reset, I would mostly emphasize on the lifestyle. Lifestyle being what you eat, how you move, how you sleep. If there is alcohol use, how do you use your alcohol? Is it responsibly? And if in terms of water intake, how do you take your water and all that? So I would advise this to be in a family sort of setup. I would advise you to start with the little that you can do. I don't advise if today you go home, probably if you have your smartwatch or if you have your phone or a step counter, probably if you've been doing 2,000 steps a day, tell yourself, let me do 3,000 steps a day. So start small, build on it. Okay. If you've been taking 2 starches in your meal, stop the 2 starches and take 1 starch, because starch is energy giving foods, and probably the amount of energy that we, the board people or the executive, expend is not as much as you want to. So I usually tell my patients, if you're a mjengo worker and you're the people who carry the sand and the cement, that's when I will probably consider prescribing for you 2 starches. Otherwise, everybody else should be on 1 starch. Even the mjengo worker, I'll tell them take 1 starch, but let's talk about how much, the quantity that you're taking. So if you've been taking 2 starch, take 2 starch. If you've not been taking any proteins in any meal, every meal should have a protein. Remember, I said, if at all you live with nothing, live with the fact that you have to build muscle. Muscle are built by proteins, amino acids. So you need that protein. And remember, by the time you're getting into your 40s and 50s, you're not even absorbing as much as the 20-year-olds or the 15-year-olds. So you need even more. So if you're not taking protein in every meal, please start taking a protein in every meal. Reduce your starch intake. Look at the frequency of your meals. If you're taking multiple meals a day, ask yourself, do I need those multiple meals a day? There's a concept which has gained a lot of momentum in metabolic health space, which is what we call time-restricted eating, which I think is commonly known as intermittent fasting. So if you're the person who can do the intermittent fasting, ask yourself how many hours. Remember, you don't need to keep stimulating your pancreas to produce that insulin. That insulin is what is causing the weight gain. That insulin is what is causing insulin resistance and making your diabetes worse. So do you actually need to drive yourself into diabetes? So small steps which you can take to be able to change your lifestyle. Do this as a family. If you're eating the protein, everybody eats the protein. My patients say these proteins are very expensive, but I'd say you'd rather eat that chicken or that fish instead of me coming to prescribe the Ozempic, which is also quite expensive if you look at it. So have a sport. If you play one sport, please, that would be good for you. If you love it, do it as a group. It'll make it better because you motivate each other as a group. If you decide to go hiking once a week or once every 2 weeks, build that group and do it together. So have this health club, which you can form with your family or friends. It goes a long way at the end of the day. And then before you do all that, please get to know your numbers. What is your HbA1c? HbA1c is the average sugar for 3 months. Forget these ones we are doing here. This one is not accurate. So if you found your sugar is normal today, that doesn't mean you don't have risk. you have risk. Please check your HbA1c, check your lipid profile. How are your cholesterols? Because we're getting a lot of younger population coming in with strokes, coming in with heart attacks, as compared to what the books say. Because now this used to be known as a disease of the affluent sedentary lifestyle. Now everybody is eating all the wrong things. So we need to look at your liver function tests, your kidney function tests. Let's look at your urine to see if there are any proteins, so that we can be able to assess the risk where you are at, so that we can be able to develop that 90-day plan. But at the base of the pyramid, at the end of it, is your lifestyle modification. What you eat, how you move, how you sleep. Remember, if you're not sleeping 7 to 9 hours of sleep, you're not doing well. And please, the 7 to 9 hours is not from 1 a.m. to 10 a.m. The best sleep is between 10 p.m. and 2 a.m. If you are to sleep, that is the best sleep. Science at least has shown that. So it's better to be to sleep early and rise early. Thank you.
Thank you so much, Dr. Rilwan. And of course, Dr. Rilwan is available at the Lion SightFirst Eye Hospital in Loresho, Monday to Fridays, and mostly she's there during the morning sessions. So if you'd like to see her, if you'd like to have further conversations with her, please do visit us at the Lion SightFirst Eye Hospital in Loresho. We have had such a good session because we were few and we were able to engage very well in our session. And back to the MC.
One question as you step out, your cards and contacts, you can leave them Daktari
Yes.
with the rest of the team. And if I go to the gym every day, is it okay to have 2 boiled eggs every day? If I'm a gym rat, do I have to eat 2 eggs every day, boiled eggs?
Come again?
Gym. For instance, I'm always in the gym. So the idea of taking eggs every day, 2 eggs, what does that?
Eggs. Oh, eggs is protein. Very
Eggs-
good
so
source
it's-
of protein.
Uh-huh.
Very good source of vitamins, by the way. So it's a good thing to have your eggs. In the morning at least. Yes.
How
yeah?
many is too much?
So the recommended protein is 1.2 grams per kg. So if you're 100 kilos, you can take 120 grams of protein in a day, per day.
That's
1.2 grams per kg per day. So
Okay.
calculate your body weight,
Mhm.
hit it by 1.2.
right.
So that is what your recommended protein is per day.
All right.
So you can break it up for your meals,
Yeah.
but ideally we advise to break it up instead of taking it all in one meal,
Sure.
so that you don't get that protein load. So the protein load, if a patient has chronic kidney disease, the kidney cannot burden excreting that much protein. So
Right.
we for our patients with kidney and liver issues,
Yes.
we have to measure the proteins that they take.
All
But
right.
if you're a healthy individual, especially, like I said, for the age group above 40,
Yeah.
proteins, muscle, build muscle.
Very